In part 1 of our series, we introduced the 8 research teams funded by the Sabin Vaccine Institute that have been working over the past year to understand and address the social and behavioral drivers of vaccination acceptance, demand, delivery, and decision-making in their communities. In part 2, we learn about the methodology, how they designed their studies and public health interventions to uncover the rich and nuanced findings we can achieve with social science research and respect for community knowledge. Successful, localized public health interventions require significant community involvement. Sabin's social and behavioral research grant partners work with people closest to the issues because those same people are the closest to solutions that are sustainable. Community partnership and co-design is what sets Sabin's grant partners apart.
So far, what's been most exciting about my work are 2 main things. First of all, working with young community leaders. Through this program formation we developed as community researchers. And the second thing that I'm most excited about is this intervention/experiment we're carrying out with institutional leaders, NGOs, and decision makers through this transdisciplinary platform. This is the first time we're carrying out an intervention of this sort, where we want to create a dialogue and use evidence and research as a boundary object to start building bridges among different stakeholders to create a more pertinent intervention and to create a more pertinent plan to increase the vaccination coverage from a transdisciplinary perspective.
For our work, it's been guided by the WHO BESD framework, that's the Behavior and Social Drivers framework, where we used human-centered design, HCD design approach, to co-design and co-disseminate targeted messages with trusted messengers to increase vaccine uptake among the citizen group. We've been able to, work with trusted community influencers or messengers, as we would call them, to address some of the concerns the communities have mentioned being the reason why they've not taken the COVID vaccine. So we've worked with these communities to address those concerns. What really excites me about our work is we're using a participatory approach. So in this case, we identified and engaged, trusted community messengers in co-designing and co-disseminating, targeted messages to, increase COVID vaccine uptake among vaccine hesitant, adults and healthcare workers.
In terms of our methodology, we chose to use a phone survey for this study, and this is something a little unique in Liberia. We thought this was an important methodology to start to investigate, especially during the time of COVID, where contact should be limited to reduce transmission. It also is a more cost-effective approach when field research is very expensive. And so as a result, in order to gain buy-in for this methodology, we've taken many steps to make the public aware, including messaging on radio that reaches national audience, as well as through social media pages. That includes through video, kind of an acted out scene where somebody is describing the scenario of having been called by one of our team members, and then someone else kind of alleviating concerns and letting them know, oh yeah, no, that's a legitimate opportunity, and here's why you should engage with the school public health and answer the questions. We also opened a hotline so that if a data collector were to call someone and they expressed concerns, the data collector could refer that person to the hotline, and on the other end is me or another one of our investigator team who can address any questions or concerns and hopefully add confidence that the study is in fact something real and that we're going to use the information for good.
We actually learned that what we hypothesized is that there would be slow uptake also in the healthcare industry. Actually didn't happen. And our collaborators, the CHASL, actually had been very, very active in promoting vaccinations in their own ranks. And as our data showed, it's over 90% of their persons, whether they're physicians, whether they're nurses or working in the hospital, are vaccinated. So we actually had to shift our thinking. And through our collaboration with the government that had done national surveys and the work with CHASL, we learned that in our own research, we learned that what really is necessary to help prepare the people that work in hospital settings to be more effective as they reach out to their community that don't have as high an uptake in the vaccine and have many questions that go unanswered. So what they have told us, what our survey participants and our qualitative participants have told us, is that they would like to have more assistance when it comes to learning how to more effectively talk to the people that already trust them.
What excites me most about iHear Vaccine Equity is its participatory nature. It keeps the communities that we work with at the center of the project. We work with the transgender and disability communities, and we have people from the same communities as part of the research team, as part of our advisory board, and we regularly meet with them to discuss the research design. And so they are not mere participants, but co-designers of the project itself.
We conducted a mixed methods research study to understand critical aspects and phenomena surrounding COVID-19 vaccination in the context of MSM living with HIV. In the first phase, we conducted in-depth interviews with 42 MSM living with HIV across Thailand via telephone and in person. We also conducted interviews and focus group discussions with over 50 healthcare providers, community groups, affiliated HIV care clinics in red zone provinces with maximum COVID-19 infections and control to gather insights and perspectives of providers' views on people living with HIV's attitudes, vaccine acceptance, and experiences during COVID-19 vaccine uptake. We then identified themes, codes, and patterns from the qualitative evaluation to further construct a quantitative questionnaire and conduct a survey among 300 people living with HIV across Thailand. The study was conducted in 3 phases to highlight the data stages, including the qualitative, integration, and quantitative phases. We analyzed the data from in-depth interviews and focus group discussions, performed data integration, and constructed a quantitative tool assessing social demographic, vaccine information needs and seeking patterns, acceptance and hesitancy, HIV stigma and barriers of the uptake, as well as recommendations for the COVID-19 vaccine service delivery.
Community involvement is a pillar of our grant partners' research to design insightful, effective, and sustainable public health interventions. Now that the teams have worked diligently to design and implement their research, what have they learned? In Part 3, our partners detail the emerging findings from their projects.